Hello, everybody. My name is Dr. Amit Shah. I've been a consultant medical and hematologist oncologist for 13 years, working in Leicester. The session will be around 30 to 45 minutes. Hopefully, we'll be able to get it within the 40-minute bracket. And the subject will be ovarian cancer, the new normal, standards of care before, during, and after the pandemic. There'll be a few polls throughout this, maybe 6 or 7. They'll pop up. So please feel free to leave your decision or a choice on the polls. Anyway, let's carry on. So we've got quite a few slides to go through. So we'll scoot on. Any views, it's important to have this disclaimer. Any views or opinions expressed by the speaker should be his own opinion, and MDforLives does not endorse or confirm the views of such speaker. MDforLives does not make any warranty, express or implied, and disclaims any liability or responsibility for the accuracy and completeness of any opinion and views expressed by the speaker. Okay. This lecture will be broken up into 3 parts. There will be part 1 will be ovarian cancer pre-COVID-19. Part 2 will be ovarian cancer during COVID-19. And part 3 will be ovarian cancer post-COVID-19 and the future. After that, normally we would have a Q&A session, but I'm really keen to get your experience, your opinions on COVID-19, how your practice has suffered or related to a lot of the things you'll read about today or hear about today, and what you've done to mitigate any risks as well. Or if you haven't been able to do that, please share any opinions you have on how your practice has been affected by COVID-19. So, introduction, COVID-19, of course, is a severe acute respiratory syndrome, appears to be zoonotic infection, so from animals. Genetic analysis shows similarity to bat SARS-like coronavirus. COVID-19 is the disease, SARS-CoV-2 is the virus. It's transmitted via respiratory droplet receptor here. And the World Health Organization declared the coronavirus disease to be a pandemic on March 11th, 2020. Globally, as of yesterday, around 7:05 p.m., there have been 225 million confirmed cases of COVID-19, including 4.6 million deaths. As of 15th September 2021, a total of 5.5 billion vaccine doses have been administered. You can see the higher incidence in darker blue, Alaska, USA, Brazil and Argentina, Russia, India, the Middle East as well, France, Great Britain, and lower incidences, which is quite surprising, Greenland and Chad. So make of that as you will. What is ovarian cancer? I think everybody here will probably know what ovarian cancer is, but a quick recap. These are different types of ovarian cancer. You have epithelial ovarian cancer, which is the most common type, where it's developed on the ovaries and then into the fallopian tube. You have familial breast ovarian cancer syndrome, which is inherited. You have germ cell ovarian cancer, which occurs when cancerous cells develop in the cells that form the eggs and the ovaries, and then stromal cell ovarian cancer. And these are the stages you'll have. Stage 1 is where cancer is found in one or both of the ovaries. Stage 2, cancerous cells are spread from the ovaries to other parts of the pelvis, such as the fallopian tubes or the uterus. And then it can spread outside the pelvis to the nearby lymph nodes, diaphragm, intestines, or liver. And then stage 4, the cancer is spread beyond the abdomen to the lungs or spleen. So obviously that's the gravest risk. We'll talk more about that in a moment. So ovarian cancer, female cancer statistics. You can see breast cancer obviously is the predominant cancer in females, followed by numerous other cancers. Ovarian cancer doesn't make up too much within this field. but it's still a pertinent issue. It's the 5th most common type of cancer, causing maximum number of deaths among women. The probability of a woman being diagnosed with ovarian cancer is 1 in 78. 1 in every 108 women is likely to die of ovarian cancer. Older women, specifically 63 years or older, have the highest risk of ovarian cancer, and it's more common in white women than Black women. The rate at which women are diagnosed with ovarian cancer has been slowly falling over the past 20 years, and we'll come into that again later on. These are statistics from cancer research from the UK. So we've had 7,443 new cases of ovarian cancer. This is a few years back, but this is cancer research's latest information. So this is open to the public. There have been 4,000 deaths from ovarian cancer in 2016, 2018. And these are generally the same from 2019 as well. So this is, again, pre-COVID we're talking about. There's a 35% survival rate of ovarian cancer, as in 10 or more years survival rate. And 11% of ovarian cancers are preventable. So, of course, we as physicians are trying to mitigate that and manage that preventability. So this is from the American Academy of Family Physicians. Key recommendations for practice on initial screening. This is clinical recommendation. Women should undergo diagnostic imaging with transvaginal ultrasonography if there is a strong clinical suspicion for ovarian cancer based on clinical presentation or a pelvic mass. The evidence ratings you can see over here. So C is a general consensus. A would be consistent, good quality, patient-oriented evidence. So there is strong evidence from the USPSTF, which is the US Preventive Service Task Force, and the AFP that recommend against routine screening for ovarian cancer in asymptomatic women. So that's a bit of a controversial idea, and it's been adopted in the UK as well. I know a few physicians that disagree with that, especially if you're trying to get the disease early, but it's been recommended through data. You should not screen for ovarian cancer in asymptomatic women. They also recommend that women with a family history associated with an increased risk of harmful BRCA mutations be referred for genetic counseling. We'll talk about BRCA mutations again later on in this presentation. The ACP recommends against routine screening of pelvic examinations in asymptomatic women. So we have a poll now, just to ask, let's see here. Do you think asymptomatic women who are not known to have a higher risk of hereditary cancer syndrome should still screen for ovarian cancer? So I see there's a few comments saying yes, maybe 1 out of 4, 2 out of 4. See, that's the difficulty we're facing. There's a whole logistical issue about treating women earlier or screening women earlier, and maybe that's high in the mindset of HCPs and also the governing boards. So I'll let that roll for a little bit more. So ovarian cancer survival rates by tumor stage and type. So the survival rates, you can see here, it's broken up into invasive epithelial, stromal, and germ cell. If the tumor is limited to one or both ovaries, there's 92% 5-year survival, and it's 96% in germ cell, so a high probability that there'll be extended survival. If the tumor involves one or both ovaries with pelvic extension, that rate reduces, but marginally, so it's still acceptable. If a tumor involves one or both ovaries with metastases outside the pelvis and or regional lymph node metastases, it drops quite considerably, almost to 39% in invasive epithelial, still quite high in stromal and germ cell in terms of 5-year survival. And then stage 4 distant metastases other than peritoneal metastases, it drops considerably, 17% in some cases to 28%. So if you're at stage 4 and you have invasive epithelial cancer, there's a low probability that you'll survive. after 5 years, and the same with stromal and germ cell. So again, we're trying to reduce the cancer moving to stage 4. Okay. Genetic syndromes with increased risk of ovarian cancer. BRCA1 and BRCA2 are high up in the mutations that we will look up. There's 25% to 65% risk percentage that you'll have a BRCA1 or BRCA2 mutation in hereditary breast and ovarian cancer syndrome. So it's important to test for BRCA1 and BRCA2. It's seen in Ashkenazi Jews. It's 10 times more common. So look out for any of your patient population that has Ashkenazi Jewish background. Then you have other syndromes like hereditary non-polyposis, colorectal cancer, which is Lynch syndrome, MUTI-H associated polyposis, Peutz-Jeghers syndrome, and P10 hamartoma tumor syndrome. There's not much data there, but there might be some mutations in MLH1, MLH3, MSH2, and others. You'll see an increased risk of colon cancer, endometrial, and ovarian cancers in this patient population. So if you can, test for this as well. We'll again move on to what other mutations that are being exhibited in certain patients, which you might be wise to test for. So again, this is still pre-COVID we're talking about. The indications for ovarian cancer, genetic risk assessment and genetic counseling. If there's a known mutation in a, so this is basically, if you have a known mutation in a susceptibility gene, if you have ovarian cancer, if the patient has breast cancer diagnosed by age under 45 or over 45, sorry, 46 to 50, 51 to 60, or if they have various other factors, as in if they have 2 relatives with primary breast cancer, 1 relative with breast cancer, 1 relative with epithelial ovarian cancer, 2 close blood relatives with breast and pancreatic cancer, if they're Ashkenazi Jews, and various other things, even a male blood relative with breast cancer. All of these are high risk for ovarian cancer. So it's best to check that background and see if they tick any of these boxes. Only one of the criteria is required, whether the woman has ovarian cancer or not. I'm sorry if I'm skipping through these slides very quickly. You can always contact me and I can give you the slides and rewatch the video at your own time. We have a lot of slides to go through. So please forgive me if I'm going through quite a lot, but this is a general overview of pre-COVID, how we made our decisions. Moving on pre-COVID to lab testing in ovarian cancer. Complete blood count, you would do a blood chemistry, serum biomarkers, cancer antigen 125, a CA125, it's a common biomarker that is tested. Its diagnostic utility depends on disease risk and stage at the time of presentation. If the CA125 is elevated in about 80% of, CA125 is elevated in about 80% of epithelial ovarian cancers overall, but in only 50% of early stage epithelial ovarian cancers. Still, it's important to test for CA125. Other serum biomarkers under investigation that we will look into later on in the presentation is inhibin A, B, HE4, serum alpha fetoprotein, and quantitative beta human chorionic gonadotropin for germ cell tumors. So these are biomarkers that are being looked at. There are other biomarkers that are being looked at as well. Sorry, my camera's getting a bit strange. It's because it's very sunny. The treatment for ovarian cancer, initial stages, surgery is a primary treatment for ovarian cancer, used for staging and cytoreduction, which is called debulking. It can be curative as well, so very useful to try surgery first, unless there's a risk of surgery. Then you can also do fertility sparing surgery involving a procedure called unilateral salpingo-oophorectomy, which preserves the uterus and contralateral ovary. It's an option for women with early stage invasive epithelial ovarian cancers, or if the lesions have low potential for malignancy. You can also do post-surgical adjuvant chemotherapy, which is recommended for late stage disease and stage 2 cases, but generally not indicated for disease confined to the ovaries. You can also do neoadjuvant chemotherapy, some pre-surgical chemotherapy, although this has no advantage over post-surgical initiation of chemotherapy. Surveillance recommendations for epithelial ovarian cancer. So this is before COVID-19. We still had to put patients on surveillance. So a gynecologic oncologist would visit every 2 to 4 months for 2 years, and then every 3 to 6 months for 3 years. There'll be annual visits after 5 years. There'll be a physical examination, including pelvic examination. Again, you would test for CA125 consistently, or other tumor biomarkers every visit, if there's any elevation. There'll be genetic counseling referral, if not previously initiated, especially if it moves to stage 2. You will look more for different genes that might indicate why the ovarian cancer has progressed. Again, you do complete blood count and blood chemistry, chest CT, PET CT, PET, and then chest radiography as clinically indicated. This was the evaluation pathway. Pre-COVID, this was by NICE and in America as well. We followed this. Women presenting with ovarian cancer related symptoms or signs, if yes, you do a history and physical examination, including genetic risk assessment. Then if you suspect an ovarian cancer or other adnexal mass, if yes, then transvaginal ultrasonography and other diagnostic workup like CA125. And then if it progresses, if there's an abnormal suspicion for ovarian cancer, you'll be referred to the gynecologic oncologist who will carry out diagnostic staging and risk-reducing surgeries. If there's no ovarian cancer suspected, you'll still do workups as clinically indicated, and then it goes to a risk assessment. If there's an increased risk of family history, as mentioned before, if yes, you refer to genetic counseling. If there's high risk genetic mutation carrier, again, you'll eventually lead to gynecologic oncology referral. If no, you'll consider long-term hormonal contraceptive use if appropriate, and it's the same as if there's an average risk of ovarian cancer. And then the treatment pathway, when a patient was found with ovarian tumors, there'll be a clinical examination. Again, this is pre-COVID. If it was, you do clinical examination, CT and MRI and CA125 check. If the patient's on early stage after all the checks, you can do a histological analysis and surgical staging, and then you'll stage them into stage 1A, 1B, up to stage 3. If it's 1A, fertility sparing surgery in younger patients or observation. If it's more to the 1B range, you would probably do a total abdominal hysterectomy and then omentectomy, and then same with 1C to 3. You'll move on to complete optimal cytoreduction, which has shown excellent efficacy, and then platinum-based adjuvant chemotherapy, and then you watch and wait after that. If you've done the clinical examination, you found they're at advanced stage, you'll do cytological histological analysis. It's based on the performance scores, so the ECOG score. If it's less than 2, and you have PCI, peritoneal cancer index of less than 15, less than 15, you do debulking. Over 15, you'll move them on to neoadjuvant chemotherapy. And then it's based on if it's complete response, partial response, stable disease, or progressive disease. If it's progressive disease, you might change the chemotherapy, and then you'll check to see if it's, again, progressive. You can move back to changing another chemotherapy regime. And then eventually you're going to move to debulking surgery. And then you might move on to an anti-VEGF like bevacizumab, which was in its infancy at pre-COVID. It was used intermittently, and a few physicians weren't so sure about adjuvant chemotherapy with bevacizumab, but it was being rolled out, and for me, I thought it was an excellent option. Treatment pathway for ovarian cancer has relapsed. Again, pre-COVID, we're talking about. You're looking at biomarkers. Once the relapse is, that's when you're doing genetic counseling. You're looking at biomarkers. You're looking to see if they have single tumor lump. Again, the performance score is important, the EGOG score, or if they have multiple lesions. If they have multiple lesions, you might move on to systemic therapy, and that's dependent on if they're platinum sensitive or platinum resistant. And then you're basing it on complete responses, progressive diseases. That will determine what chemotherapy regimen you will be put on. And then you could also do a BRCA test as well to move them onto a PARP inhibitor, which again was in its infancy pre-COVID. It was being rolled out in many hospitals, but not to the extent that you'll soon see when COVID hits. So this is part 2, ovarian cancer during COVID-19. Let me just quickly check. Did we do, yeah, so the next poll will be coming. So what is the impact of COVID-19 on ovarian cancer patients? This is the crux of this webinar. That's why I skimmed through the first bit. What was the impact? These are the general impacts. You had delayed treatment, closure of treatment facilities, cancellation of surgeries. There was a mandatory COVID-19 testing before surgery. There was alternative management. So there was a preference to oral therapies and virtual monitoring, which is a huge change. In our practice, it was a huge change because a lot of it was face-to-face. There was delayed diagnosis, of course, appointment cancellations, changes in diagnosis, facility hours, and reduced follow-ups. And the quality of life was affected. There was a higher level of worry, abnormal depressions, and abnormal anxieties. So the general overview of COVID through all cancer types. So when COVID hit, in the 2021, we had a thing called the Oncovid Study, assessing over 3,000 cancer patients throughout Europe who also had COVID-19. The case fatality rate was greater in UK patients. So this is more UK centric, but for me, it's interesting in that why were UK patients being affected more than the rest of Europe? So 40% were being affected by COVID-19 compared to the rest of Europe. And risk of death from cancer was 47% versus 33% in the rest of Europe. So that's a big thing. In the Oncovid study, again, it was found that the determinants underlying this mortality had to do with a higher frailty of patients with cancer in the UK. These are the reasons. You had virus variants. In the UK, you had far more virus variants. You had the Indian offshoot. We had the regular COVID offshoot. So there was a lot of offshoots. There was the aging cancer population, of course. I'm not sure why high comorbidities was noted in patients in the UK, but the statistics prove that in the Oncovid study. Patients in the UK had poor prognosis scores, that higher tumor stage status scores, and higher levels of smoking and alcohol consumption compared to others within Europe. So maybe after Brexit, it is wise to stay in Europe and not come to the UK. Our quality of life isn't as high as Europe. Despite equal levels of COVID-19 severity, equal proportions of intensive care admission, and equal use of mechanical ventilation, UK cancer patients were less likely to receive anti-COVID-19 therapies. So we were less likely to receive corticosteroids, antivirals, or IL-6 antagonists. A significant percentage of UK patients were not benefiting from the vaccines. So a great number of B-cell and hematological malignancies that our patients had in the UK would lead to weaker immune systems and higher susceptibility to the virus. So we weren't doing well with the vaccines. There are a lot of data gaps in this study. So Oncovid, I think, is a continuous study, and there'll be other offshoots of this study. So we look at that with interest. Oh, sorry, I didn't go back to the poll. The next poll question is, let's move it on. So, poll. So, oh, there's 50-50%. Let me look at this. In the last slide, do you think asymptomatic women who are not known to have a higher risk of cancer syndromes should still screen for ovarian cancer? It was 50-50, so that is really interesting. Let's move on to the second question, second thing. What percentage of cancer patients in your practice in all cancer types were not seen at all throughout 2020 due to COVID concerns? So what percentage of your cancer patients, let me launch it, in your practice in all cancer types, so not just ovarian cancer, were not seen at all? Why? Which did you put on watch and wait? Which did you decide, well, they can't be treated at the moment because we haven't got the logistics or infrastructure for that? Let's move on. The major issues in diagnosis of all cancers during COVID-19. Between March and September 2020, Cancer Research UK estimated that 3 million fewer people were screened in the UK for any type of cancer. Again, this might seem a bit UK-centric, but I'm pretty sure it was similar throughout the world as well. Maybe not Chad or Greenland for whatever reason. Maybe it's the fish they have in Greenland. Let's just say that. And I'm sure Chad probably has fish as well. Anyway, between March and September 2020, Cancer Research UK estimated 3 million fewer people were screened in the UK for any type of cancer. Between April 2020 to March 2021, the number of patients starting their cancer treatment was 42% lower to that in pre-pandemic. So that's a huge amount that were not starting their treatment for whatever reason. So there were more than 380,000 fewer urgent suspected cancer referrals in the UK between this period. And we're going to see a graph later on that will show you the effect of this. So it's down 13% compared to that in pre-pandemic, 57,000 for urological cancers, 23,000 for lung cancers. The number of key cancer diagnostic tests carried out between March 2020 to 21 was 21% lower compared to pre-pandemic. So 3.9 million of these missing tests were radiology and 700,000 endoscopy. So I think that's 309.9 thousand. Let me move back, sorry. 45.5 thousand fewer patients started cancer treatment in the UK compared to that in pre-pandemic. Again, this is showing the effect of COVID on our cancer patients. And not just ovarian cancer, we're looking at all cancers here. At stage at diagnosis, provisional data suggests the number of patients diagnosed at stage 1 or 2 was 32% lower in April to October 2020 compared to that in pre-pandemic England. That's a huge amount that weren't diagnosed early. Again, we're talking about diagnosing early, but we weren't doing it during that period. The number diagnosed at stage 4 appears to be less markedly affected. That's good. I think that proves that during COVID, we were triaging patients to make sure we get those at the higher stage, but maybe that's defeating the issue of it because we are trying to get early disease to patients so we can treat them in more lines of progression, more lines of treatment. At stage 4, you have like you saw before, you have a lower prognosis, a low overall survival prognosis. So it looks pretty bleak there. The routes to diagnosis. Although the number of patients diagnosed following an emergency presentation was largely similar to pre-pandemic in April to October 2020, diagnosis through screening were down by over 60%. Those via an urgent suspected cancer referral was down by 20%, and those by routine other GP referral was down by 30%. So we weren't referring patients enough, especially after screening. The waiting time, so this is again a huge consistency throughout the world during COVID. Targets were consistently missed throughout the pandemic. So we would set up targets pre-COVID, and of course during COVID it was severely affected. They were missed. They were also frequently missed pre-pandemic because maybe they set the bar too high. 89% of patients were seen within 2 weeks of an urgent suspected cancer referral between March 2020 to March 21, compared with a target of 93%. That's not it doesn't seem a huge amount, but when you consider the patient population of cancer, that is considerable. Targets for 31-day waits were missed during the pandemic for all UK nations except Scotland. And for 62-day waits, targets were universally missed across the UK. So yeah, no, it wasn't good. For a thing called a fear factor was a huge thing during COVID. You could see that in the newspapers, and as you stood out, you walked out into the shops or just walked out into the public, the fear factor was palpable. Sorry, let me go back. So you had postponed or cancelled procedures. So biopsies, testing, screening, surgery, chemotherapy, and radiation therapy was postponed or cancelled. Most hospitals cancelled non-emergency and non-urgent patient visits during the early stages of the pandemic until a safety plan could be put in place. I'm sure this is very apparent to everyone on this board about no matter which country you're in, this happened everywhere. There was a laborious wait for decision makers to strategize an optimal COVID-19 plan. There was a lot of twiddling of thumbs, especially in the UK, which delayed patients' treatment and costing lives. Transport was affected during COVID. Travel was severely affected. Patients were nervous to commute on crowded public vehicles to get to the hospital. Less well-off patients having procedures on the NHS that were coming from faraway towns or villages to clinics within major cities were concerned about long-distance travel, and then also finding food and accommodation when they didn't have the money for it. Things like import and shipment of healthcare appliances and PPE kits and medicines were also affected as there were closed trade routes, numerous checks, which caused further delay. Of course, the psychological effect was huge. Women had a higher level of worry, anxiety, and depression about their cancers, breast cancer, ovarian cancer. They worried about having cancer at a younger age. So it was just heightened during COVID. They were anxious about scheduling their cancer treatment or surgery. Would there be a delay in their oncology care? So stage 1 or stage 2, there were a lot of patients thinking, well, why is my cancer being delayed? Why is my treatment being delayed? And then we explained we have to see stage 4, and then it would just add to that anxiety. Patients would fear that they were immunocompromised, so could not be treated with novel treatments like PARP inhibitors. They were apprehensive about the logistics of telemedicine. So you don't think about it too much, but a lot of people didn't have strong internet connection. In certain areas of the UK, the connection is really poor. So if you're having a video telemedicine meeting and your internet is down, then the oncologist or physician has to wait for the next suitable time, and they haven't really got that. Computers as well, a lot of people didn't have the right computers. So it's a little thing that you don't notice, but it actually affected a lot of people. Of course, women worried about, well, people generally worried about social isolation and loneliness from having to self-isolate from family and friends. And where was their support network? We talk a lot about support network and giving support tools to cancer patients, but a lot of people didn't have that. They worried about a lack of physical exercise due to self-isolation. This is the extreme cases. You didn't want to go out to walk. It didn't affect all of us, but there's a few people that didn't want to go for a walk or run. And a lot of people were just to go to the gym, and those were closed. So they're worried that they couldn't afford to eat a healthy diet. So diet and exercise is absolutely key. So someone's just raised their hand, sorry. Sorry, is there anything important? I saw someone raise a hand. Anyway, I think, where are we? Stage 25 there. They worried that they couldn't afford to eat a healthy diet if they were furloughed or had lost their jobs during the pandemic. So yeah, again, patients lost their jobs during the pandemic. they didn't have the income to pay for a diet. I mean, a sustainable diet or a diet that could be deemed healthy, affected their health. Self-isolation affected their health. There's a huge psychological effect that cost patients dear. Delayed workups, ovarian cancer. So fear factor, you had the delay in workup. Since ovarian cancer symptoms are vague, so these are the early stage symptoms that you'll look at: frequent urination, bloating, feeling full quickly when eating, pelvic pain. Again, these can be vaguer symptoms. Changes in bowel habits and fluid collection, pain with intercourse or back pain. So if you were to phone up a busy healthcare practice, maybe you get a skeleton staff there, and a number of times they were unable to decide over the phone if the patient was suffering from ovarian cancer or if they were just symptoms of COVID or simple urinary issues. So that was a delay in workup. The skeleton staff weren't equipped and trained to really understand if this patient really had ovarian cancer signs. So this is a little graphic to explain what happened during the delay in treatment. Unfortunately, the COVID-19 pandemic has forced hospitals to postpone several elective surgeries, including many cancer surgeries, to secure the resources for the expected increased number of COVID-19 patients. So hospitals and clinics, they didn't shut, but they had a vast proportion of their wards and wings totally devoted to COVID-19. And so those cancer patients that should have been treated weren't getting treated. This resulted in a delay in surgery, debulking surgery. There was a delay in laparoscopy and radical surgery procedures. There was a delay in chemotherapy, neoadjuvant chemotherapy, cytoreductive surgery. Women had to have additional cycles of chemotherapeutic drugs while waiting for surgery. So it was a bit of a headache. There was also delays in immunotherapy. Considering the effect of COVID-19 on the host immune system, cancer immunotherapy treatments suggested to be used with caution because of immune-related adverse events. So we couldn't put patients on the right immunotherapies in that initial stage because we were worried about abnormal immune response in the case of a SARS-CoV-2 infection. Surgery and other local and systemic therapies could also be extremely harmful to the patients harboring asymptomatic COVID-19 infection. So there was a lot of patients that weren't getting their treatment. Reasons for delay. So clinical trials were also affected. So let me just see. So have we missed a slide? So yeah, so let me just put a poll on. So let's just see the result of the last poll. What percentage of cancer patients in your practice in all cancer types were not seen at all throughout 2020? So 11 to 20%, 71, so 20%. So it's not as bad as I thought it was going to be, but then you do have over 31% in 14% of people. So that's bad. So let's move on to slide 25. Was there a delay in treating your OC patient during COVID? Sorry, to move back. Yes, a considerable delay. Only marginal. No, not at all. Let's go on. So let's go into clinical trials. Sorry, let me just quickly see what the time is. Yeah. So lower volunteer rate. So clinical trials were important, of course. And the fact is, during COVID, there was a problem with clinical trials. It wasn't a huge problem, but it was affected. Lower volunteer rates due to safety concerns and need for private clinical trial nurses to work at community hospitals. So there's a lot of clinical trial and private nurses in different clinics and hospitals that moonlighted almost in community hospitals due to staff shortage, and there were other nurses that were unwilling to treat COVID-19 patients or go to hospitals where COVID-19 was rife. So yeah, there was normal clinical trial establishment to work in a hospital. So There was also several outpatient visits discouraged in trial designs. So if a trial had various outpatient visits, that was discouraged. You would have maybe a bulk where you would have 10, 15 days stay. And a lot of patients couldn't do that or were unwilling to do that in a COVID environment. Most affected in ovarian cancer was an ongoing, so there was a clinical trial called NCT03, as you can see here, at the Dana-Farber Institute, which was assessing the safety and pharmacokinetics of REGN4018 as monotherapy in combination with cemiplimab. It's a bispecific antibody that binds both mucin-16 and CD3. And so that was affected. That was the major ovarian cancer trial that was affected. So we were waiting for that trial data that had to be put back. There were issues with supplying the medicines required for a study. So generally, clinical trials now will, during this period, would mail medicines to patients, and they would have to pick them up in person. So that was a logistical issue. And if during a study, a trial patient tested positive for COVID-19, the patient should be removed from the study and must follow the recommended guidelines by the institution. For a significant period, restrictions were also put on all the research personnel, including research coordinators, to work from home. So again, staff, coordinators were not able to work in the facilities and do the vital sign testing and investigations that they needed to do. It had to be done from home, and that was dependent on if they had good internet connection, etc. So there were delays in there. Ovarian cancer during COVID-19. So we put a lot of patients in watch and wait. So if their ECOG score was 0 to 1, this is just at my hospital and a few other hospitals in our network in the UK. If their ECOG score was 0 or 1, the Karnofsky grade of 100 to 90, we would put them on watch and wait. If they had poorer prognosis scores, then we would perhaps see them. It depended on their FIGO staging score. You had stage 1 to stage 2B with watch and wait. So that's a huge patient population where ovarian cancer, you didn't see the patients at that early stage, where you could have actually given them really good treatments, started them on a management pathway that could have really helped them with newer medicines as well in the future. But because we weren't seeing them, it created a backlog. I'm going to start another poll here. So let's look at the other poll. Was there a delay in treating your OC patients during COVID? 25% say yes, considerable. 50% say only marginal. So that's surprising, not as much as I thought. And no, not at all. 25% not at all. So, and we'll end that poll. And sorry, share results. Okay, so you can see there. So stop sharing. Let's look up. Did you put stage 1, 2B OC patients on watch and wait? So just interested, personally, I'm just interested in how you, so did you put stage 1 to 2B patients on watch and wait? Even at stage 3, I know a few practice didn't even put stage 3, didn't even treat stage 3. They put stage 3 on watch and wait. We didn't go that far, but yeah, okay, we can see straight away this surprising results, which I'll share with you later. Let's move on. The management plan during COVID-19. Patients previously on oral treatments. So if a patient was on a maintenance therapy, oral chemotherapy, or hormone therapy, we would give them an email, and we would request blood and instrumental tests and registration of current signs and or symptoms, except for new symptoms or clinical or radiological signs of disease progression. And then we would, so email, and then followed by phone or telematic call from the PCP. Generally, it was phone because we had issues with telematic calls, especially in the elderly patients or those with learning difficulties. or even patients like we mentioned before that were poor, inexperienced with technology, or couldn't afford good systems. Sorry, I received a message. Is everything okay? Yeah, please let me know in chat if everything's running quite well. So the management plan of ovarian cancer during COVID-19. So this was a general management plan during COVID-19. A patient would express desire to have a regular physical exam or be referred to have for their family physician to have a physical exam or screen. But unfortunately, we wouldn't allow them in. So during the height of COVID-19, we weren't allowing patients with new diagnosis or clinically urgent signs or symptoms. These are the symptoms. So the risk, we would mention to every patient the risk of hospital visit. We would try to move patients onto a scheduled visit into telematic contact or phone. We would try to do that. The risks of that are OC symptoms aren't either noticeable in the early stages of the disease, or they mimic common stomach and digestive issues that are often mistaken for minor ailments. So it's important to recognize symptoms and try to catch the disease before it's spread beyond the ovaries. So we weren't doing a lot of this because, we weren't catching them, we weren't catching patients early enough. So if a patient had to come in, I think this is the case in every hospital I know, the day before a scheduled visit, a phone telematic pre-triage was considered mandatory. So we would decide via triage what patient, what their symptoms were, if they had the COVID-19 infection. If the symptom was absent, if they didn't have COVID-19 or any of the signs of COVID-19, we would confirm their visit. Otherwise, on the basis of the reported symptoms, the patient was sent to the emergency room with a fever path versus the COVID-19 path was performed. We didn't allow caregivers allowed into the unit, including the waiting room. So some people have a support network where they can only do procedures with a caregiver. We weren't allowing that. And after triage, only one family member was admitted in case of clinical need. And then on-site pre-triage was expected for all scheduled access and included measurement of body temperature, infrared thermometer. So we'll see this in the next slide. Oh, sorry. Someone is quite loud. If you can put yourself on mute, please. No access was allowed for patients with fever and or respiratory symptoms. Surgical masks, I think PPE is prevalent throughout. Everyone knows about the PPE issue. Surgical masks and gloves were obligatory, much to the bane of everyone in our hospitals, nurses and doctors having to wear those visors and masks during hot days, long hot days. It was a nightmare. FFP2, FFP3 masks were mandatory. All visits to our unit were for patients needing explanation and discussion of a histological report. For triaging patients to follow up versus medical treatment after surgery or after radiotherapy in patients managed by a multimodal approach, there were no admissions for surgery or radiation treatment. So during that height of COVID, there were no admissions for surgery or radiation treatment, and MDT meetings were virtual. So again, COVID-19 was affecting a lot. This is the management plan for if a patient had a suspected COVID infection. You would see if they presented with a dyspnea or cough, it would be determined on their body temperature. If it was less than 37.5%, chest X-ray, they didn't have COVID-19. And then you rule out other causes of infection. If their body temperature was over 37%, suspected COVID-19, you would have to do chest imaging, isolation room, infectious disease specialist evaluation. So it's just delaying a patient's procedure, and it's just adding to their worry. The management plan, identifying COVID-19 infection before surgery is crucial to minimize possible complications. A retrospective analysis of clinical data of patients with COVID-19 who underwent elective surgeries from January to February 2020 reported that 44% of patients required ICU, intensive care unit admission post-operatively due to COVID-19 related severe symptoms. So that's a huge thing. Besides risk of post-surgery complications, there was also a risk of potential contamination for the medical staff working in the surgery room during procedures. Along with open surgery, laparoscopic procedures could also participate in this possible contamination. So surgery room, laparoscopic procedures, there was a high risk of contamination. Previous studies on DNA viruses indicate that viral components could be identified in surgical smoke and spread to nearby individuals. So we had to look at surgical smoke as well. During the current pandemic, the cancer research community realized the need for a special center or hubs free of COVID-19 to treat cancer patients. So we had cancer hubs where oncologists were supplied with the right supplies and equipment to provide adequate care that cancer patient needed. So we had to hire out new clinics and hubs to treat our cancer patients because we couldn't do it in a hospital because of the COVID risk. And to minimize the risk of virus and reduce the number of postponed procedures, COVID-19 free cancer hubs were suggested to play a crucial role in cancer care. Yeah, so I was in a cancer hub. I know a lot of other people that were. So some of the alternative therapeutics were PARP inhibitors. This is a mechanism of PARP inhibition. You included, so it's a poly-ADP ribose polymerase hormonal therapy. It's a targeted therapy that can be used as an alternative to intravenous therapy. There have been numerous over the last few years randomized placebo-controlled trials of PARP inhibitors that have demonstrated excellent PFS when used as maintenance therapy. So that was ideal during COVID. We thought, okay. So do we have a slide to, yeah, slide 33. Okay, yeah. So PARP inhibitors were pushed forward due to COVID-19, which is a very positive thing for the PARP inhibitor. So we had Niraparib, rucaparib, and olaparib. A phase 3 study evaluated PARP inhibitors' efficacy against intravenous chemotherapy, especially with those with BRCA mutations and platinum-sensitive relapsed OC, showed that PARP inhibitors can be a good alternative to intravenous chemotherapy. So during that 2020-21 period, PARP inhibitors really came to the fore. So we've got a little chat here. So a PARP inhibitor is, so someone's asked what an example of PARP inhibitor is. So you have Niraparib, talazoparib, rucaparib, and olaparib. And they're called poly-ADP ribose polymerase hormonal therapies. It'd be wise for you to look up on these. You can see the mechanism here. They work with BRCA mutations. Yeah, so we haven't got time to look into PARP inhibitors exactly. There's been a lot of ovarian cancers presentations on PARP inhibitors, so I would really recommend that you look at those. But they have shown excellent efficacy in ovarian cancer. And this is just during the COVID period. We'll move on to after COVID and the various trials that are showing the improvement with a PARP inhibitor with chemotherapy compared to just chemotherapy alone. So if a woman with ovarian cancer does not respond to platinum-based chemotherapy, she may receive an oral PARP inhibitor therapy to maintain the disease in these trying times. So it was a good maintenance drug. Just to show you a few, let me go to another poll. Sorry. So let me just show the results of this poll. So did you put stage 1 to 2B OC patients on watch and wait? It's pretty 50-50. No, so patients stage 1 to 2, maybe 2 were seen. So that's really good. That's something we didn't do as much in the UK. So let me stop sharing and let me look at the next one. So let me launch this. So was there a significant uptake in immunotherapy or targeted therapies in your practice as a reaction to COVID? This won't be relevant to every single clinic because PARP inhibitors were not accessible to a lot of countries. But for those that were, can you just tell me, was there an uptake in immunotherapy and targeted therapies because of COVID? Or were you introducing them before? If you were introducing them before COVID and it's a natural course of the progression, then you could put no. But if you thought, okay, we need an alternative for the maintenance period or an alternative to bringing a patient in, we'll put them on a PARP inhibitor, like rucaparib or Niraparib, then olaparib, then please put yes. Thank you. Let's move on. So this is the monthly numbers started cancer treatment following a screening program. So we saw these statistics earlier. You see here the drop from before COVID to during this nightmare period of COVID. But then you can also see, because we were putting mechanisms in place, as mentioned before, this triage system, we were improving this statistic, and it was going back to pre-pandemic levels, thanks to good, maybe not as quick as we can, management plan, but a good management plan that we incorporated, especially during the August to November period. Again, you can see here monthly numbers of urgent GP referrals. It dropped considerably during this period. So it's almost a lost generation that we had here, but luckily we came back and it's improving considerably. And we'll show you why it was improving considerably in the next part. Data shows the positive steps during the peak period resulted in eventual uptake in procedures, in diagnosis and treatment. So you can see again this number of endoscopy tests undertaken in England, that dramatic fall from pre-pandemic. And then you can see the improvement here. We went back to pre-pandemic. This is a unifying, universal movement from every HCP to really, the amount of effort that we put in to get back to pre-pandemic was incredible. Not only from the HCPs, the healthcare professionals, but also the decision makers who eventually got themselves into gear and were excellent. Radiology tests, again, the drop was very apparent in this April, March to May period, and then we got it back. The proportion of patients receiving first definitive treatment within 31 days of the cancer diagnosis. So the first definitive treatment, so the first treatment they will get, it dropped considerably, total cases, and then we moved back to a good percentage. And proportion of patients treated within 62 days of an urgent GP referral, again, dropped considerably, and we moved back. We've got a little chat here. So yeah, please use Q&A feature to ask your questions. Thank you. Let's move on to the next slide. So this is part 3. So we've talked about the effect of COVID-19, huge effect on the outset. And you can see from that graph the effect, but then what we did as a unifying HCP body is worldwide to really mitigate that risk and bring it back to pre-pandemic levels and even above pre-pandemic levels. It's a worldwide, a brilliant management plan that we all put in place. So part 3 is ovarian cancer after COVID-19 in the future. What has been put in place to mitigate the pitfalls that occurred during the height of the pandemic? So let's look at the poll result before we move on to this last bit. So let's share the result of this. Was there significant uptake in immunotherapy targeted therapies in your practice as a reaction to COVID? Yes, 67%. So that's brilliant. I think the fact that you're encouraged to try immunotherapies and targeted therapies, which wasn't the case. A lot of oncologists, a lot of physicians were very conservative. They were not too conservative, but pre-pandemic, there was a bit of conservative. There were surgeries enough, chemotherapies enough, but you could see the data before COVID even, that the strength of these immunotherapy and targeted therapies were fantastic. If you can get the mutation, if you can get the patient on the mutation, and we'll see how you can do that in a second. So it's really encouraging news to see. Okay, so I think we'll do another poll here. Okay, we'll look it up in a second. Okay, so this was the delivery of care post COVID-19. So modern day and the future. This is what's happened. There's been a change in delivery of cancer care during COVID-19 and afterwards. Now we've had telemedicines and virtual check-ins. Really good at this telemedicine, virtual check-ins, messages pinged to your phone to say, how are you feeling? Various checks that you have to do on your phone or before you even enter the hospital or via email. You have various questionnaires you have to fill in before entry. There's social distancing in waiting rooms and facilities. Although I will say now, I think it's not as good now that we've come out of the second wave. In our hospital, I have noticed that people are coming and conglomerating again, which is something that we have to look at. And that's important. I think we don't want to go back to what happened with COVID-19, especially if there's a third wave, but we'll talk about that in a second. So you have had drive-on blood draws and injections. So going to drive-through blood draws and injections in different places. So it's stopping the flood of people going into hospitals. Use of masks within facilities has been really good, I think, and we've really used that well. And of course, temperature checks before entry, that's really good. So telemedicine, that is probably the new norm now. I think maybe 40% of my patient population is now via telemedicine, 30 to 40%, whereas it used to be 20% or 15%. I would see most of my patients face-to-face, and I know that's consistent in a lot of physicians. Virtual registration will be imperative, as will subscription and tracking via various healthcare apps. So we've seen the influx of new apps and health apps. Everyone's going to have an app somewhere on their phone eventually for their health. The use of mask PPE will remain in healthcare, as will social distancing, as we mentioned before. And double vaccinated patients will get priority preference. So this is the next question. That's a really controversial thing that I've seen in a few clinics and hospitals and everywhere else. The double vaccinated patient getting the priority preference, and it's creating a lot of issues. So let me start a new poll. Let me launch this. Do double vaccinated patients get preference in your practice? Okay, let's move on. So ovarian cancer after COVID-19 in the future. Home is where the hospital is. So this is a new thing that's, I think a lot of people are trying to move towards. A lot of physicians and nurses and people as well are trying to do healthcare at home. There's a healthcare at home team movement that's happening in the UK, which is implementing strategies for managing cancer patients. You can do a lot of self-diagnosis at home. There's a lot more tools for blood measurement and oxygen and heart rate. There's more video consultations with primary care physicians. There's more take-home medicines and fewer nurse visits as well. So it's a real movement towards a patient ameliorating themselves at home. Post-COVID again, this is the pathway, new NICE guidelines for ovarian cancer. If a woman presents to the GP, they'll be given information support first, and then you'll move on to maybe urgent referral based on physical examination only. So refer the woman urgently. Physical examination identifies ascites and or a pelvic or abdominal mass, which is not uterine fibroids. If the patient hasn't got a need for urgent referral, NICE have told us when to test for ovarian cancer. Carry out tests in primary care if a woman, especially 50 or over, reports having any of the following symptoms on a persistent or frequent basis, particularly more than 12 times per month. Persistent abdominal distension, feeling full, loss of appetite, pelvic or abdominal pain, increased urinary urgency and or frequency. We can consider carrying out tests in primary care if a woman reports unexplained weight loss, fatigue, or changes in bowel habits. We will carry out appropriate tests for ovarian cancer in any woman over 50 or over who has experienced symptoms within the last 12 months that suggest IBS, because IBS really presents for the first time in women of this age. The testing for ovarian cancer, we would test serum against CA-125 in primary care. If it's 35 international units per milliliter or greater, arrange an ultrasound scan of the abdomen and pelvis. So at least we've got really strong guidelines now from NICE, where during COVID, we weren't getting the right information. We were a bit more confused as to who to treat. Now we've gotten some really affirmative guidelines. So that's really good. So when to refer, if a woman who has normal serum, less than 35 IUML, or CA-125 or 35 IUML or greater, but a normal ultrasound, we will assess her carefully for any other clinical causes of her symptoms, and we'll investigate if appropriate. If no other clinical cause is apparent, we'll advise her to return to a GP. And if her symptoms become more frequent and or persistent, then we will refer her to an oncologist or gynecologist or whoever is the appropriate secondary care. So if a woman referred to secondary care with suspected ovarian cancer, so we'll do secondary care tests. Again, we will measure the serum CA-125 like we did pre-COVID. In women under 40 with suspected ovarian cancer, we'll measure levels of alpha-fetoprotein and beta-HCG, as well as serum CA-125 to identify women who may not have epithelial ovarian cancer. We'll perform an ultrasound of the abdomen and pelvis. If the ultrasound and clinical status suggests ovarian cancer, we'll perform a CT scan of the pelvis and abdomen to establish the extent of the disease, and will include the thorax if clinically indicated. If they move on, if there's a risk of malignancy index score, we will refer them to a specialist MDT team. So we'll refer all women with an RMI 1 score of greater than 250 to a specialist MDT. Then we'll give them information if a patient is newly diagnosed with ovarian cancer, and then we'll manage them in the following way. So women with suspected early stage ovarian cancer, we will stage and roll of systematic retroperitoneal lymphadenectomy. So this is an optimal surgical staging constitutes. These are the following criteria for optimal surgical staging: midline laparotomy to allow thorough assessment of the abdomen and pelvis, a total abdominal hysterectomy, a bilateral salpingo-oophorectomy, and infracolic omentectomy. We will look at biopsies of any peritoneal deposits. There might be random biopsies of the pelvic and abdominal peritoneum, and retroperitoneal lymph node assessments. If the stage 1 is confirmed, we might put them on 6 cycles of carboplatin. If they move on to stage 2 to 4 ovarian cancer, the new change in during the COVID-19 was the introduction of trametinib, which was a MEK inhibitor. You can see in the NRG-GOG trial on women with recurrent low-grade serous ovarian cancer, treatment with trametinib resulted in a 52% reduction in the risk of disease progression or death, with a median PFS of 30 months versus 7.2 months standard of care. So it was a strong option to give trametinib for, like we said before, as oral alternative to intravenous chemotherapy. This is during COVID, and we're still carrying it on now, and to reduce risk of immunosuppression. It's important to note that the option to give olaparib, Niraparib, or rucaparib, which are the PARP inhibitors that people asked, and I'll answer that question later, instead of chemotherapy plus maintenance. PARP inhibitor at first relapse PARP to reduce admission and risk. So I'm trying to work out what this says. In the event of high rates of coronavirus infection was removed. So olaparib, niraparib, and rucaparib with a high rate of coronavirus was not accepted. It was thought that under NICE that they might be less effective than standard therapy and were no longer needed due to lower rates of coronavirus infection. So the choice of PARP inhibitors during this COVID and even now was discouraged by NICE because other therapies, like standard therapies, were recommended, but trial data now that we're going to look at in a second shows that PARP inhibitors with combination are showing excellent efficacy. You can move on to primary surgery that we mentioned before, and first-line chemotherapy, cytotoxic chemotherapy, and then maintenance treatment after first-line chemotherapy, and then second-line and subsequent chemotherapy if a patient progresses. We move on to maintenance treatment after second-line of subsequent chemotherapy. So chemotherapy was recommended throughout. Paclitaxel with cisplatin or carboplatin is a good alternative. The anti-VEGF bevacizumab was not recommended under the first-line chemotherapy option. Again, there's trials that are coming up that prove that, not prove, but are showing that maybe bevacizumab might be a useful alternative coming up, especially in those with certain mutations. The NICE guidelines continued maintenance treatment after first-line chemotherapy. So second-line subsequent chemotherapy. So this is the recommended second-line topotecan, topotecan, pegylated. So yeah, with taxane or gemcitabine. Second-line, so maintenance treatment for first-line chemotherapy, olaparib plus the anti-VEGF bevacizumab. So PARP plus bevacizumab was recommended for the first time by NICE. So that was a huge change in post-COVID. So that's for the maintenance treatment. There's been a complete or partial response after first-line platinum-based chemotherapy plus bevacizumab. So PARP inhibitors with an anti-VEGF was recommended for use if there's been a complete or partial response after first-line platinum chemotherapy, and if the cancer is associated with homologous recombination deficiencies, HRD. Niraparib, again, a PARP inhibitor, is an alternative that was recommended by NICE. So second line, so we said second line, if there's a skeletal related event, denosumab, which is a treatment for osteoporosis, is recommended. And then if it progresses, if patient progresses, we'll have a maintenance treatment after second line with subsequent chemotherapy. And olaparib is recommended if they have a BRCA1 or BRCA2 mutation. Rucaparib is an alternative option, and niraparib, these are all PARP inhibitors, if they have BRCA mutations and have had 2 courses of platinum-based chemotherapy, or they do not have a germline BRCA mutation and have had 2 or more courses of platinum-based chemotherapy. So if they've had 2 courses of platinum chemotherapy and they've progressed, a PARP inhibitor is recommended and it's shown good efficacy. And if they progress beyond that, beyond the PARP inhibitors, at this moment, NICE recommend palliative care, which is opioid peritoneal carcinomatosis. But there are other options as well coming up. So what is the future predictive biomarkers? Finding the right biomarker for OC patients to target those biomarkers early. So a crucial point in immuno-oncology is to find reliable biomarkers in order to identify the patients who will respond to immune checkpoint inhibitors, ICIs. Several biomarkers have a high level of validations, such as PD-L1 expression. So we've seen a high level of PD-L1 expression in ovarian cancers. MSI as well, microsatellite instability, has shown, where is that party over here? But yeah, that's shown, and BRCA mutations, and also tumor mutation burdens have shown, BRCA mutations and tumor mutation burdens have shown contradictory results, but still worth checking. So these are the biomarkers that we found that have a high prevalence, or at least a marked prevalence in ovarian cancer, and it's something that we should really bear in mind. Again, that's dependent on finding a patient early enough, which we weren't doing during COVID, but now we can do with facilities like this, next-gen sequencing. So new sequencing technologies will have a significant impact on cancer diagnosis, management, and treatment. Human genomes are thousands of cancer genomes sequenced with NGS panels they'll provide a roadmap of the normal human genome and landscape of mutations in cancer genomes across many cancer types. So now we'll be able to identify multiple biomarkers in one patient and treat them accordingly and as an individual, which is a huge landmark. So are we on to a new? So yeah, let's move back again. So these are some of the trials that we're looking at now over the last year or so. So there's been a Javelin trial, Keynote trials, looking at various novel immunotherapy and targeted therapy drugs, checkpoint inhibitors, PD1 and PD-L1s, and CTLA-4, CD80, and CD86 pathways have been checked. So you have drugs like atezolizumab, pembrolizumab, which is a very famous drug now, which is anti-PD-1, and nivolumab, are showing good progression, good scores in ovarian cancers. You can see 50% overall response rate in nivolumab, 8% in pembrolizumab, or 11% in pembrolizumab for those with recurrent OC. So yeah, it's showing good, considerable, acceptable PFS, good overall survivals, and good overall response rates. So these are trials that we should all look at and note. Immune checkpoint inhibitors, so CPIs, and PARP inhibitors, and anti-angiogenic drugs like anti-VEGF, like bevacizumab, and these combinations and triplets are, again, the new mechanisms that have really been pushed through the last year, especially during COVID. There's a lot of trials that are coming through that were really focusing on bevacizumab with durvalumab, rucaparib as well, and nivolumab. So it's a lot of trials. I think you should make a note of some of these trials and keep an eye out on the results. A lot of them are recruiting or active at this moment. So we really get to see how these are going to affect ovarian cancer, these combinations and triplets with chemotherapy regimes. Let's see how they work in the future. Some of the other future drugs that we're looking at, adavosertib, which inhibits the WEE1, has emerged as a promising compound that is able to regulate G2M transition and sensitize tumor suppressor p53 mutant cells to chemotherapy. Again, this is a very novel mechanism. So if you're confused about what this is, do your own research, because I think the results aren't in properly. There's still more trials that are going to be coming through, but it's just something to keep your eye out on. There was the Tapasio Keynote 162 phase trial of Niraparib, the PARP inhibitor with pembrolizumab, the anti-PD-L1, in OC patients, and there was an overall objective response rate of 25% and an objective response rate of 45% in patients with BRCA mutated genes. So again, check for BRCA mutations is really important. There was a Velia trial, again, this happened this year and last year, which assessed veliparib to standard frontline platinum chemotherapy, followed by maintenance veliparib, which resulted in significant improvement in PFS compared with PFS of those who received placebo. So further drugs that people are looking at. One of the huge progressions in health has been CAR T therapies. I think a lot of people have heard about this. CAR T cells redirect T cells to recognize cell surface antigens in an HLA independent manner. Despite CAR T therapy successes in hematological malignancies, the efficacy in solid tumors is less dramatic and is confounded by the risk of a CRS, which is cytokine release storm. But they're looking at this. There have been other toxicities. Again, they're looking at this, looking at how they can work around this, because the progression, the prospect of a CAR T therapy is fantastic. T cell receptors transduced T cell, so there's TCR-T therapy, is currently in early phase clinical trials. Again, they're showing promise. And MUC16 CAR T cells have specific killing effects on MUC16 positive ovarian cancer cells in vitro. A lot of this could be alien terms to do. We haven't got time to look into this at the moment, but just note down MUC16 CAR T and just CAR T cell. If you haven't heard of this, there was an article that I wrote in MDforLives that are showing real promise in CAR T cell therapies. Another progression has been in something called CRISPR, Cas9 technology, which knocks out which has been shown to knock out the tumor suppressor encoding gene BRCA1, NF1, P10. This is in mouse cells, but it's shown real promise. 2010 to reveal new insights into the heterogeneous cellular origins of HDSOC, novel methods of molecular stratification and newly discovered DNA repair components. The last year there's been a real progress in this single CRISPR Cas9 technology. It's creating the perfect human. Really, I think I wrote an article about this in MDforLives. I think it's really important that you look it up for yourself. This has been a good TED talk from the creator of CRISPR-9. Look it up. It's a fantastic new technology. Defining the predictive value and clinical utility of detecting resistant mechanisms in real time will be the bedrock of realizing individualized therapy in OC. So real-time monitoring is important. You can look at 3 different phrases. Quality of life assessment is important. And yeah, sorry, I think I've gone over the allotted time. So this is the end. Far from being the final nail in the coffin, COVID-19 allowed health bodies to focus their attention, making use of MDT, CCGs, VACs, guidance governing boards with the physician and patient always at the forefront. The result was a multi-headed force that was not only able to manage the crisis, but come out with strength the other side, with strategies in place to ensure the health professional and patient know exactly what affirmative and proactive actions to take when a similar crisis or even a third wave strikes. Sorry, I think I've run well out of time. I didn't have a thing. So if you have any points, that's the end of the thing. I'll let you start to write down. MDforLives is a premier healthcare market research firm. Medical doctors can register for free and become a part of this global community, take up surveys, participate in quizzes, and earn attractive honoraria. So we've had a few questions here. I don't think I'll be able to answer them. I'm really sorry. I think we've run out of time now. Any kind of questions you have, like on PARP inhibitors, I really suggest you look up. There's various videos on things like PARP inhibition. Just look up Niraparib or olaparib. Look up the efficacy of those. Best combination therapy to use. Again, we've shown you the nice guidelines. Surgery, chemotherapy are good options, but then if you want, look at the results of combinations with an anti-VEGF like bevacizumab or a PARP inhibitor. They're really showing promise. So I think that's it. Anyone else has got an opinion on? I don't think we have enough time, but I'm really sorry about that. We've overrun. So I think that's it. I think we can say thank you, and I'll be coming back later on. So thank you very much, everybody. I'm really sorry for going over, but I hope you enjoyed it. I hope you were informed. Please contact me on amitshah@execs.com if you want to see the slides, and then you can look at you can do your own research on everything. Thank you very much. Okay, thank you.